Have you been told you need to stop doing what you love, whether it's exercise, running, or a sport? Well, here at Dynamic, we don't like that answer. In this podcast, we'll talk to leaders in the health and wellness space from Southwest Florida to get the solutions you need to get you back to doing what you love. Welcome to the Dynamic Naples Podcast. Hey, what's going on? It's Dr. Chris here. Today, I want to talk about the sacroiliac joint as a pain generator. It's kind of a fun topic, and believe it or not, it's kind of controversial. So our field, just like any other, has trends, and trends can lead to controversy. I want to bring this up because I think it's important for people to understand that recovery is kind of a moving target, right? It's not a black and white type of thing. So when I was in school, the sacroiliac joint, we did a whole module on it, and it was just taught very matter-of-factly, like this is a thing that causes pain. But then I learned later in practice that a lot of clinicians feel that it does not cause pain. You'll find on social media forums, places like Reddit or on podcasts, I've heard a lot of therapists talk about how there's no way this can cause pain. And I'll get into some of the major arguments, but one of them is that it barely moves. If it doesn't move, how can it cause pain? So let me back up and just describe a little bit of what the sacroiliac joint is and what it does. So the sacroiliac joint is the joint between the sacrum and the pelvis, or the iliac crest. That's where it gets named, sacroiliac. They call it SI joint for short. And it's a continuous, think of the pelvic girdle as a continuous circle with a little bit of motion at that SI joint. That's what happens when we walk. It kind of shifts slightly back and forth. And it's a couple millimeters we're talking, very little movement. The whole area, it looks like it's shrink-wrapped in tons of big, thick, strong ligaments. So it's inherently a very stable joint, a very almost fixed structure, and its job is to transmit force from our legs to our upper body, because our hips are kind of our main drivers, our main engines. Sacroiliac joint dysfunction is just a generic term that describes any kind of issue coming from that area. And this falls into the whole hypomobility paradigm that physical therapists kind of view the body with. So what that means in general terms, that things tend to be either too stiff and cause pain or too loose and cause pain. Now herein lies one of the major problems, because this is a joint that barely moves, so it's very hard to decipher, is it moving too much or too little. But the nomenclature around this tends to fall into hyper or hypomobility. Some of the classic symptoms of a SI joint dysfunction is pain that's specific. You can point to it with one finger. It's actually called a Fortin finger test. You can point to it. It's like right where your low back becomes the hip. Kind of like those dimples of your low back, right around that area. That's the general location, or I should say specific location for SI joint pain. Symptoms are described as pain when rolling, particularly rolling in bed, pain when driving for long distances. You can have sort of that piriformis pain or pain in the buttock. It can turn into sciatic pain, and commonly you'll get groin pain associated with it as well. Probably because of pubic symphysis, which is a spot in the front of the pelvis where the two pelvi meet, and there's a disc right there at that pubic symphysis, and theoretically it can set a little bit oblong and cause some pain. And that's why I think the groin pain can be associated with this. Okay, and I just Googled it because I was curious. The plural of pelvis is definitely not pelvi, it's pelvises. So there's a little history here too. So in the 1900s, there was actually a pretty common diagnosis of SI joint pain. And then some changes in research started to shift sort of the idea and thinking behind it, and it turned more into herniated disc. Right? So there's a lot of research came out on that and started in the 30s. Stu McGill came around, started working with pig cadavers, and then Nachemson and his colleagues came out with an intradiscal pressure research paper. And then in 1977, the MRI was invented. And then it became all about herniated discs, and we still see it to this day where, there's sort of this over-reliance on MRIs and, the obsession around bulging discs. Not that that's wrong, but I think it can create a lot of confusion. So the pendulum has swung away from the sacroiliac joint, but I kind of think it's starting to swing too far in the wrong way. So let's dive into some of the arguments for and against why the SI joint may or may not be a pain generator. Now, where am I getting this information? I haven't, seen any research papers talking about how the SI joint does not cause pain. This is mostly just from conversations with colleagues, either in person or online, a lot of forums, what I've heard from people say on podcasts. So the probably the most common thing you'll hear is that, well, it only moves a couple millimeters at best. How can we say that thing is hypermobile or hypomobile? How can we truly assess that? How can that cause pain? And so if we can't really feel how much it moves or doesn't move, how do we assess this thing, right? That's the other thing too, imaging. So you can't really see much on an X-ray or MRI as far as a dysfunction for the SI joint. You can see some inflammation, but that doesn't guarantee that there's pain coming from that area. But you can't see like a rotated pelvis on an image. Not well, at least I've never seen one. So this gets into sort of the problems with the nomenclature. I think this is where a lot of therapists get kind of turned off by the SI joint. Because it's common to have a patient walk into your door and they've seen another provider, maybe another PT or chiro, and they've been told that they're all twisted. Their hips are rotated, or they've got an upslip or a downslip. And a lot of therapists will kind of cringe at those terms because it doesn't really, you can't feel it that well. And this, I think, gets into, our experience as students. Because what you're supposed to do, so we learned in class at least, you got someone standing in front of you, facing away from you, and you're supposed to feel their PSIS and kind of get a sense for so PSIS is kind of the top corner of your pelvis there. And you're supposed to assess, is that higher or lower? Is it pushed forward, pushed back? Same thing, we come around the front of the pelvis, you're supposed to feel that and kind of just with your eyes and hands be able to tell, is it out of position? And so as a student, you're kind of like struggling, have all this pressure on you, and you're trying to figure out, why can't I feel this? And I think that's a part of where some of our bias against this whole thing comes from. And then there's the whole leg length discrepancy thingy, right? So another thing that I think a lot of therapists have a bad taste in their mouth with. So another test for the joint is you have them lay on their back, and it's a supine to sit test. And then you have them sit and you look at their ankles to see if one shifted forward or backwards. Does that show what we call a functional leg length discrepancy? And if there is a discrepancy, then that could be a positive sign of an SI joint issue, just because of the relationship between the femur and the pelvis. But then you realize, well, just about everybody has some bit of discrepancy. So how much is too much? Not to mention, maybe they kind of laid down on the table in a funky way, a little bit shifted. I mean, it's not really a valid test. There is some cluster testing, a series of 5 different special tests you can use, but also in our world, the special tests are very sort of poor. That's why we come up with cluster testing. But I've run through the cluster tests with people that I consider to be positive for SI joint dysfunction, and they almost always test negative. Not to mention some of these tests that we use. Let's say there's one called a Faber test, where you put the person's leg. Kind of looks like if you were to sit in a chair and read the newspaper and cross your leg onto your foot onto your knee, with kind of that position, but laying on your back. That's the Faber test. So it can test positive for a whole bunch of different things. You could have just a stiff groin and it could not feel good. So our special tests are not great for the SI joint either. So this presents a major problem. How do we diagnose this thing? So I think that kind of sums up the majority of sort of arguments against the SI joint as a pain generator, at least from what I've heard. So if you happen to be a therapist, listen to this and I missed something, please write in the comments, because I truly just want to know. But going back to the diagnosis part, if you're an ortho listening to this, you're probably thinking, oh, he's forgetting about the whole injection thing, which I think is a strong argument for the SI joint being a pain generator. So right now, the gold standard to diagnose an SI joint issue is to inject it with cortisone. And if your symptoms are 75% better, that's a strong indicator that that is where the pain is coming from. So I think that's a pretty good case for why this thing can cause pain. The other piece that I think is really puts forth a strong argument for the SI joint is that this happens a lot to pregnant women. So as I mentioned, the whole pelvic girdle is like enshrouded in tons of ligaments, and ligaments are a bone-to-bone attachment. They're there for stability. Well, when you're pregnant, your body secretes a hormone called relaxin so that you can widen your pelvic girdle to deliver a baby. So, if the theory is right that too much motion of this joint can cause pain, well, this happens a lot to pregnant women. And this brings me to one of the tests that I use often. One of the special tests, again, not a perfect test, but something that I think is a pretty strong indicator, is the active straight leg raise test. So if you're a patient, you're laying on your back, you lift your leg up in a straight way, and if that provides pain, that's half the test. Then I go and put my hands on your pelvis and kind of squeeze the pelvis together to provide stability to the pelvis. And if that makes the pain go away when doing the straight leg raise, that would be considered a positive test. And I think that's a pretty strong indicator. I mean, you've got a pelvis that may be too mobile, and then it can't accept the load of the leg, and you stabilize it, and suddenly it can. That's pretty clear to me. And that's a test that is easy to reproduce. I'll usually do it like 3 or 4 times to make sure I'm not getting any kind of flukes there. And when it consistently does that, then I'm like, okay, we're looking at SI joint issue. So, I mean, clearly I'm in the camp of I do think this thing can cause pain. And I do have a little personal bias, too, because I did, years ago, fall down an elevator shaft. Maybe you guys know the story. And I broke my pelvis, and I broke the iliac crest. And I developed very clear SI joint pain. And through the rehab and, the whole paradigm of how you fix an SI joint, it completely resolved my pain. So with that in mind, let me just start talking about how I sort of assess and address the SI joint. Because I get pretty good success rates with this. I would say most of my patients are better in 4 to 6 visits or something like that. At least get the pain, get rid of the pain, and then it's all about keeping it from coming back, which to me just means getting stronger. Right, so I don't think that hypomobility or stiffness of this joint can cause pain because one of the things you can do sort of end stage, if nothing else has helped, is get an SI joint fusion, and they tend to do pretty well. So if you can fuse a joint and make someone feel better, how can hypomobility or too stiff of a joint be a problem? So in terms of assessing this, I basically generally feel like I know that's the SI joint just in my history taking of the patient. So when they're first coming in talking to me and they're describing where their symptoms are and what provokes it, and they can point to it with one finger, that to me is like, all right, now the rest of this evaluation is about ruling out other things. So let's talk about what things it could also be. So we've got disc issues. That's kind of the L4, L5 issue area. If you have pain there, it could be SI joint or disc. But typically with a disc, you'll have a clear set of other indicators. You can have pain shooting down your leg. That can get tricky because you can get that also with SI joint. But they usually will have a passive straight leg raise test versus an active. This is getting into weeds a little bit. The other thing I'll be looking at is I do look at the leg length discrepancy. I don't know, just why not? It's quick and easy to do. And, I'll do a trial treatment. So if I do find that one leg is significantly longer than the other, and I'm talking like an inch or two, not like a millimeter, I'll do what's called like a SI joint reset. It's an MET, a muscle energy technique. It's just simple little push-pull thing. It can't hurt you, and I find that, it's really quick and easy, and people generally feel better like immediately after doing this. So that's another sort of check mark in the box for what else could this thing be. If they've done that supinous test, and then I give them an SI joint reset. Then I have them stand up, walk around, bend over, do whatever motion was provoking the pain before. And if that made a change, that means I think we're on the right path. The other thing I could see it being would be a stenosis, and that's where there's a narrowing in the space between the vertebrae. And, with certain motions, you can kind of crunch down on the nerves in that area and reproduce a similar type of pain. But with that, you also typically will get radiating pain down the leg. But usually in standing, if you side bend to the painful side, so close down the joint, that'll provoke pain. And if you side bend the opposite way, they'll reduce pain. And you kind of see a opposite pattern with sacroiliac joint, where side bending towards that way usually doesn't hurt. Side bending away, you can kind of feel it. But a stenosis and a disc issue, those will usually get picked up on an MRI. So if you don't have those and you still got that pain and you've got all these other things testing positive like the active straight leg raise, then you can be pretty sure it's the SI joint. So what to do next? This is where I think range of motion probably matters the most, and some strength testing as well. So I'll look at all the muscles that basically, the big ones at least, that attach to the pelvis, and there's a lot of them. There's like 35 of them attached to pelvis and sacrum. But I'll look at the big movements. How are your hamstrings? How are your quads? How's your hip rotation? How are the adductors or hip abduction? Are you missing some range of motion? And I'm looking at big outliers. If one hamstring's like 4 degrees tighter than the other, I don't think that's a big problem. If we got a 20-degree difference, okay, this may be a contributor. Because theoretically, because the hamstring attaches to the pelvis, every step you take, you may be pulling the SI joint in one direction asymmetrically, and it'd be enough to cause shear at the joint. So what I think may be happening with, what's causing this pain, I think it comes from the ligaments. So let's just say that whole area is completely shrink wrapped in ligaments, and every step you take, that pelvis is tipping maybe backwards or forward just a little too much, maybe a millimeter extra. And this is one of those things that takes like thousands and thousands of cycles to get to the pain. It may be overstretching ligaments that are not really meant to be stretchy. And over time, they get a little looser. And maybe that creates a little bit of a hypermobility, kind of a micro instability. Or maybe that causes some swelling from the ligaments. And perhaps that's leaking onto the sciatic nerve. I think this is where the pain is really coming from. So, I basically call this a shear stress. So after I look at range of motion, and I'll mention too that I've actually seen someone's ankle be really stiff on one side from a previous injury, for example. And that causes this. And this is the way this shows up. It's kind of unique. So if they're, say, a CrossFitter and they do a lot of squatting and they do a lot of deep squatting and one ankle's way stiffer, that ankle stiffness will change the position your leg will rest in the deep part of the squat. It usually falls into an internal rotation, and that can shear the SI joint. So you have to look the whole leg. After I look at all the range of motion, then I'll look at strength, all right? Because theoretically, if you got too much motion, the muscles also hold the skeleton together. If we strengthen the heck out of all the muscles that attach to the pelvis, that will maybe help prevent it from moving. So I kind of see this as like a two-pronged approach. Fix any giant outliers for range of motion, and then strengthen basically, mostly the glute medius minimus and the hip rotators, I would say, but basically all the muscles that attach to the pelvis. So that's my basic approach. Identify it, right? And I kind of mentioned how to do that. And then it's all about resetting the pelvis and making the pain go away. So that's an easy thing to do. So I teach my patients how to do that on their own. So every time they feel that pain, they can do that little maneuver. And you can always go to my YouTube channel to see that. And then address range of motion issues, get them as close to symmetric as possible. And let me just mention that everyone's asymmetric. Like being perfectly symmetrical, it's a bit of a fallacy. That's not really a thing. But the closer we can get you to becoming symmetric, the pain tends to start going faster and faster. And then sort of that final step is to address strength issues. We'll strengthen the joint and keep it as stable as we can, and that usually takes care of it. So if you have any questions, please email me, chris@dynamicnaples.com, or go to my website, www.dynamicnaples.com. All right, thanks. Why guess when you can test? Do you get hangry or crash after a carb-heavy meal? These could be indicators that there is a dysfunction in your blood glucose regulation. If left unchecked, it can lead to irreversible changes. If you catch it quick enough, you can make diet and lifestyle changes that will get your levels where they need to be. 88% of Americans are pre-diabetic and don't know it. Diabetes underpins many of the pathologies we deal with in this country, such as obesity, high blood pressure, heart disease, and stroke. For some reason, it is rarely screened with your physician, and if they do test for blood glucose, it's usually with an A1C or a fasting glucose, which can sometimes give you a false negative. Nutrisense is a company that supplies continuous glucose monitors. We've paired with Nutrisense to get you real-time data to see how your physiology responds to glucose. The Nutrisense app lets you track your daily activity to see how food, sleep, exercise, and stress impact your glucose. You can log or import this data into the Nutrisense app to see the effect on your blood glucose levels as soon as it happens. Use the code DrChris25 for $25 off your order today. Do you have unexplained pain, or do you wonder just how healthy you are? When was the last time you had your blood tested? Blood chemistry analysis is a great tool to stay ahead of any health conditions, and now you can have control of your health with Let's Get Checked. Let's Get Checked is an incredible company that sends blood tests to your home. You can choose from over 30 different tests, whether that's thyroid function, testosterone, micronutrient, cholesterol, or C-reactive protein, which is a marker for inflammation. It is sent to you with free shipping, and you get results in 2 to 5 days. No physician referral needed. Use the code DPT25 for 25% off. You can find links in the show notes. Did you know that you can get started with physical therapy without a physician's referral? Physical therapists don't just solve pain, we get down to the root cause and keep it from coming back. We also discuss all things health, such as nutrition and lifestyle changes. If you feel that you could use some help, let's get on a free consult call. Go to www.dynamicnaples.com and sign up for a free call. Also, if you like this podcast, please give us a rating wherever you listen to podcasts. It helps us spread the message. Thanks for listening, and we'll see you next week.